Hi there, my name is Christine Chen from the Princess Margaret Cancer Centre in Toronto, and I will be presenting today an ASH 2020 update on Waldenstrom's macroglobulinemia. These are my disclosures. So my goal in the selection of abstracts today was to be as practical and user-friendly as possible in terms of the content. So I'll be covering frontline, second line, and beyond management approaches for Waldenstrom's, hopefully providing you with some tidbits to take back to your own practices. So starting with frontline bendamustine and rituximab, we've been using this regimen since the 2013 STILL trial showed efficacy of BR in a subset of, or rather in various indolent lymphoma subsets, including a small group of patients with Waldenstrom's. Since 2013, when that study was published, showing a very good efficacy and toxicity profile compared to R-CHOP. And we were happy also to see at last year's ASH that the same STILL group presented the MAINTAIN data. This was actually a study focusing on maintenance rituximab versus observation after frontline BR. And although the maintenance made no difference, we were encouraged to see in a larger subset of Waldenstrom's patients, 266 in this study, that response rates were very high and progression-free survival with BR, whether you had maintenance or not, was in the 9 to 10-year range. So BR remains our standard frontline chemoimmunotherapy regimen in Waldenstrom's. And the next two slides will focus on how we can optimize bendamustine-based treatment. This first abstract was a retrospective review of 230 patients with indolent lymphomas treated with bendamustine, a subset of which were Waldenstrom's. And they identified that lymphopenia, as not surprisingly was common in 84% of patients, developed during therapy and worsened by the end of treatment. 56% were severe with lymphocytes less than 500. And it took 9.5 months to recover it after the end of therapy. And presumably this contributed to the rate of severe infections in about a quarter of patients. These were patients requiring hospitalization. And it was interesting to see the array of opportunistic infections that they reported. There were definitely signals for increased PJP, fungal, perhaps viral. And it also was interesting to see that the approaches by investigators for prophylaxis varied, very much like what I anticipate we do in Canada. 44% didn't use any prophylaxis. On the other hand, a third of patients used both antiviral and PJP prophylaxis, and then everyone else did a smattering of other approaches. So we are not as uniform in this, in prevention of infections with bendamustine. So the take-home message here is perhaps that we should consider at very least PJP prophylaxis, so pneumocystis prophylaxis, and maybe even antiviral, much like we do for prophylaxis with FCR, up to, during and up to 12 months after bendamustine treatment. The next slide looks at the optimal BR dosing used. Again, this was not just in Waldenstrom's patients, but it was a retrospective analysis of 250 patients with indolent lymphoma treated with BR, a subset of which had Waldenstrom's. And they correlated the bendamustine dose with outcomes, response, and PFS, and found that frontline, the optimal regimen was full dose for the full 6 cycles, where there's a little more wiggle room with the relapse population to dose reduce or perhaps even truncate the course of bendamustine to 4 cycles, to 5 or 6 cycles perhaps. So why do I mention this? Because I know across Canada, many physicians will dose reduce BR somewhat empirically based on a patient's perception of frailty or their age. The median age for Waldenstrom's is 70. So it is noteworthy that age did not affect the tolerated dose in frontline. So this is just a word of warning that perhaps one should try to aim for full dose BR for optimal efficacy even in those older Waldenstrom's patients, as long as, and to avoid any empiric dose reductions just purely based on age. So I'm moving on to second line therapy with ibrutinib and beyond. And we all know that ibrutinib is used more and more in Waldenstrom's and was first approved as monotherapy based on a phase 2 trial back in 2016. And then subsequently was approved in combination with rituximab based on this INNOVATE trial, which randomized patients either to ibrutinib plus rituximab or rituximab alone. There was a cohort, RMC, of more heavily pretreated rituximab refractory disease that all received monotherapy. And so at ASH 2020, we saw an update on the with a median follow-up now up to 50 months with the INNOVATE trial. And what we can see is that by 50 months, you can see the PFS curves on the left. The PFS for the ibrutinib arm has still not been reached. It's about 70% PFS, or free of progression, by 50 some months. So that's pretty impressive that patients can continue 4.5 years and longer after starting ibrutinib and still remain free of progression. In the arm C of patients with more heavily pretreated disease, the PFS was much shorter, suggesting maybe we should be using ibrutinib earlier in course of treatment. And we started to see what we have observed with other reports, that the presence of CXCR4 mutation, which occurs in about 30% of patients with MYD88 mutated Waldenstrom's, portends a poorer prognosis when treated with ibrutinib. So ibrutinib is highly active, but alternatives really still are needed for this significant portion of patients. Now in Canada, we don't routinely, uniformly across Canada, have access to CXCR4 mutation testing, but this kind of data suggests that it would be useful to use as a marker for stratifying for treatments. So what do we use after ibrutinib? Well, there was a lot of information at ASH on alternative BTK inhibitors, both covalent binders. These are BTK inhibitors that bind at the same cysteine 481 site as ibrutinib, and also non-covalent inhibitors that bind elsewhere. So the covalent BTK inhibitors, including acalabrutinib and zanubrutinib, are thought to have equal potency, but because they are much more specific for the BTK kinase, they may affect the kinases on heart and platelets less frequently, and potentially decreasing the usual ibrutinib toxicities of atrial fibrillation and platelet dysfunction. So we've seen data before on zanubrutinib in Waldenstrom's with the head-to-head trial, and that showed similar efficacy and some variable data on toxicity, some toxicities less, some more with zanubrutinib over ibrutinib. So perhaps what we need is more of a sequential approach, and that's what this abstract from ASH showed. The study design here was for patients who were intolerant to ibrutinib and or acalabrutinib, were then put on zanubrutinib, the much more specific BTK inhibitor. And this was a very short follow-up, but all to say that you can see the swimmer's plots here with the common toxicities, and the ones in gray show that the intolerant events occurring with ibrutinib did not recur with zanubrutinib. And time will tell whether or not patients are able to stay on zanubrutinib significantly longer, allowing them to achieve perhaps deeper response. So the biggest, though, BTK inhibitor that made a splash at ASH was LOXO-305, which, as I mentioned, is a non-covalent BTK inhibitor that doesn't bind to the same cysteine 481 site of BTK that is the main site for mutations that are responsible for the majority of relapses or resistance on ibrutinib. So LOXO-305 is equipotent against patients who have the mutated BTK versus wild type. So we were very keen to see data come out from the Bruin study. This was a study in various types of lymphoma and CLL. There was a subset, small, of 26 patients with Waldenstrom's who were subsequently tested on the phase 1 and 2. These were relatively heavily pretreated patients, 3 prior lines. Most had a prior BTK inhibitor already, predominantly ibrutinib, and 2/3 of them came off study or came off ibrutinib because of progression. And the data, again, are very immature, but what's encouraging, if you look at the left, is the toxicity profile with LOXO-305 is excellent. You can see virtually no grade 3-4 toxicities. Of those toxicities we worry the most about with ibrutinib, such as atrial fibrillation and bruising and bleeding. And again, data is, the data is very immature, but we are seeing responses, even recognizing most patients were progressing on the previous BTK inhibitor. So lots to come yet on LOXO-305. So in conclusion, this was a snippet of abstracts at ASH for Waldenstrom's that I thought would be informative to our daily practice. Frontline bendamustine rituximab, highly effective. I think we're still going to stick with it. But aim for optimizing the dosing even in older patients. Consider PJP and probably viral prophylaxis extending out until there's lymphocyte recovery. And second line and beyond, ibrutinib is confirmed as being a highly effective agent with durable response. And I think just around the corner are these newer BTK inhibitors that will give us some more options for beyond ibrutinib. Thank you very much.